afternoon. So this is fourth year of Breathe 2025, and today we will discuss about pulmonary rehab in our panel discussion. I would like to call Dr. Pooja ma'am. So Dr. Pooja ma'am has done her PhD and masters with specialization in cardiorespiratory sciences. She is professor of kinesiotherapy at VSPM College of Physiotherapy. I would like to invite Pooja ma'am on stage.
Good afternoon, one and all. At the outset, let me thank Dr. Sameer Arbat sir for this opportunity, having standing in front of you as a cardiopulmonary physiotherapist and presenting few of the challenges that we both have faced as a pulmonologist and as a physiotherapist, dealing with his referred patients, which he has almost started 6 months back. And the only journey that we could share, we are not going to discuss any theoretical aspects of about pulmonary rehab, the definition, the components, which you all are very well aware of. We believe in showing you the progress of our patients, and this progress started when he started believing in physiotherapy. So this is the whole journey that I want to share for a couple of patients that he referred to me. He trusted us as making a difference in the patient's life. So couple of patients, they are still following it up with us, and one of the patient success story that I want to share with you all, so that you also get an insight as to a few months of physiotherapy sessions just twice a week can make a huge difference in patient's life. And we are talking about quality of life, we are talking about years of low hospitalization and fewer exacerbations. So where do we stand in all this scenario? So this is just an insightfulness for all of us, and without you it is impossible. Having understood that, if you don't tell your patient with the passion, I have got one very important compliment of my life till date, that people, it's very important that there is a team of rehabilitation people around, but if there is passion missing in that team, that passion comes with the pulmonologist, because you are the benchmark for that. If you tell your patient that you have to go to the physiotherapist, he will come to us, and the rest resides with us, ki how well we can show you the progress, how well we can give you the results. So this is what Dr. Sameer Arbat did to us. He trusted us, and then this is what I want to show where we are today. Though a couple, it's a start. Like last 1 year earlier, we didn't even know that, okay, I have a person like Dr. Sameer, and Sameer sir didn't know that, okay, physiotherapist could make a difference. So let's share this positivity with you all, so that everywhere, every pulmonologist believes that he needs a physio. So here's to all of y'all. So he has told me to present the challenges for pulmonary rehab. So this is what I just he has just told me to mention just 3 slides and then my work with y'all. So basically, we all know that pulmonary rehabilitation is an evidence-based, multidisciplinary and comprehensive intervention. So yes, we are actually combining the multidisciplinary team, started with Sameer sir as a pulmonologist, and then the physios, and then we have certain, the caretakers, the family members, the social workers, they are coming in loop, the nutritionists, of course. And so this is basically for the chronic obstructive pulmonary disease who are symptomatic, and they often have their activities of daily living affected because of their disease condition. And we are basically, all of us, you, me, or any one of us, we believe in improving the patient's symptoms, optimizing his functional state, and thereby we want a patient to return to their normal lifestyle. We want them to participate in social activities. We want them to participate what they were doing earlier. That is what we all aim at. So we all know that the components of pulmonary rehab starts with interdisciplinary patient education. We go to assessment aspects. Then comes our role of exercise training and functional training. Management strategies begins with all the exercise prescriptions, and if the patient needs NIVs. And then we progress further with optimization of pharmacotherapy, nutritional support, psychological counseling, so on and so forth. So, but what are the common challenges in pulmonary rehab? And that is what we have started collecting the data from the pulmonologist perspective. What do they feel, that where do they feel blocked? At least in a city like Nagpur, why aren't we getting referrals from pulmonologists? So where are we blocked? So what are the common challenges? Healthcare related system challenges and patient related system challenges. So when we look at the healthcare related system challenges, there are fewer centers and accessibility inconvenience. So any one of you, so the practicing pulmonologist, do you know who is offering pulmonary rehab services in Nagpur? Yes, please. Now that we have promising pulmonologist of the city, we are honored that we are a part of your conclave. But I really want to know, do you know where do you refer your patients for pulmonary rehab? Just tell me, suggest me one name. Maybe a tertiary healthcare center. But do you know somebody who is exclusively practicing pulmonary rehab? You need to find one, or you need to create your own physiotherapist. Those who are inclined towards pulmonary physiotherapy, and then you make your own team. So this is what we lack here. We don't know whether the centers are there and then how to access them. Second most is the healthcare professionals' awareness about pulmonary rehab programs, their guidelines. What are the recent guidelines that are available? Whom to send for pulmonary rehab? What are the guidelines? We are not aware. Lack of knowledge and referral processes. So just calling Pooja Akhtar will help. So at least we have started. At least we have started. We know we have a lot of loss to follow up of patients because most of them, they are from outside Nagpur. But the people who are from Nagpur, we are tapping them. We are giving them phone calls. We are giving them reminder calls. We are giving them encouragement calls. We are giving them free tele rehabilitation so that they at least do their exercises at home. And then lack of communication and interdisciplinary teams. So it's a humble urge to all of you sitting here that we need to take one step together, and let's pledge an oath today that we need to tap these patients who deserve pulmonary rehab, and you are the ones who would do it for us. The patient related challenges, though they can be manageable, like travel and transport. How do the patient come to us? Patients are coming from Khamla to Sadar. It's not feasible for them to call them every day, alternate days. So people are visiting me once a month. That's still all right. At least they are coming. Then socioeconomic constraints. Patients do not believe that they will be benefited from pulmonary rehab because the pulmonologist never stressed upon pulmonary rehab. So please do that at least one contact session with the physiotherapist, cardiopulmonary physiotherapist, could make a difference. If the patients are having coexisting diseases, like we have morbid patients coming to us with obstructive sleep apnea, so we really need to work on this. And then there are so many other things that the patient feel, expenses in terms of home oxygen problems, then attending the sessions. So before I just want to tell you the story of this patient called Shanti Sundaresan. She's a 73-year-old female, a case of COPD, ILD, obesity, congestive cardiac failure, diabetes mellitus, what not, and receiving pulmonary rehab referred by Sir. And this was her first session when the patient's dyspnea level was
and the first exercise
that she was not even able to understand what is a normal breathing pattern like. She was doing all her exercises sitting, hardly able to move her hands because of dyspnea. The first thing that we trained her
muscles को relax, chest को relax. हमें lateral constantly focus करना है.
in 73-year-old female. Treating her at home, she was homebound. She was taking
Breathing
with Sir.
without.
To move out
नेक की मसल्स को एकदम ढीला छोड़ना है.
Amir sir, that
नाक से सांस लेंगे,
that too
मुंह से छोड़ेंगे.
She was so fearful.
हाँ, स्टार्ट कीजिए. लंबा सांस, deep
She
breath.
just started
खूब
with
खाइए, धीरे धीरे धीरे
first
धीरे
session with
धीरे.
us. And then this was after
Small breath, small breath,
without
small breath in, small breath,
many things with her. Lot of other mobility exercises
inhale,
were incorporated for her. Then we use lot of upper limb movements because patient had lot of ONE problems. She was not able to do brisk walking. So we involved lot of upper limb movements so that her dyspnea could be taken care of very well. We incorporated lower limb training as well.
then exhale out.
Lot of bond
Inhale,
for
exhale out.
she did what squat
Inhale,
breathing.
exhale out. Maro, exhale out.
She was performing
Very good. Inhale,
everything. Her each
hold, exhale out. The slip.
So lot of
Breathe in,
weight bearing activities
breathe out.
with breathing.
Inhale, Exhale out.
This was what we trained her. And then her SpO2 started improving. Her resting SpO2 never rose 90 and above. And then after the therapy,
एक दो
20
तीन
with her,
चार.
achieved 94, 95 after exercise. So that was the achievement, that she was not desaturating post 45 50 minutes of exercise session. So then this was an achievement for me when she started climbing downstairs. The aim was so that she could go to her pulmonologist without fear. And
Inhale,
that
exhale out.
climbing and descending stairs,
Inhale,
next my
exhale out.
achieve with her without fear, without
Inhale,
oxygen support. Though she
exhale
has
out.
1 liter of oxygen
Nice.
at night, but this
Breathing control practice करेंगे.
without oxygen. Climbing stairs was equal
Okay, start.
for her. She could do it very well. And then this is what. Then
Breathe in one step,
she
breathe out 3 steps. Breathe out, breathe out.
is very
Nice.
she needs some
Breathe
sort of
in.
oxygen. So the next we did for her was we bought a
नहीं तो फिर भेजना ना अभी हाँ ऐसी का वीडियो साथ ही 97 ये वीडियो भेजना आप उनको ठीक है चलो नाइस
take her oxygen and maintain her saturation levels.
नहीं
What we did for her, and this is a small video of
मैं समीर आर्वेट के साथ से 2021 से ट्रीटमेंट ले रही हूँ तो उनके पास ट्रीटमेंट शुरू हुआ अभी तक चल रहा अभी तक और दे रहे हैं लास्ट 3 मंथ से मैं पल्मोनरी दे रही हूँ डॉक्टर के साथ और पाँच इम्प्रूवमेंट आई थी मैंने बाहर जाने के लिए मैं एस्केप करती थी सीधी उतरना करना मेरे से बनता नहीं था ये मैं डॉक्टर के यहाँ कंसल्टेशन भी जाना मैं सोचती थी 2 बार आज जाऊँगी कल जाऊँगी अगले बार जाऊँगी आ रहे दो तो दवाई तो खा लेते अभी वो पास मेरे से हट गया मैं अभी देखने के नीचे उतरती हूँ चलती हूँ थोड़ा एफर्ट्स लेना पड़ता है बट आई एम बेटर ऐसा बात इसलिए चला गया और 3 मंथ से मेरा ट्रेनिंग से डॉक्टर पूजा हुए हैं उससे आई एम वेरी कॉन्फिडेंट आई फील मच बेटर और डॉक्टर आर्वेट बहुत अच्छा टाइम में मेरे को ट्रीट करते हैं समझाते हैं क्या चीज़ है क्या है पूरा वैसे डॉक्टर पूजा भी मेरे को समझाए क्या डिजीज है कैसे रिकवर करना है तुमको क्या रेफर करना है कैसे करना है एक्सरसाइज क्या करना है इसका फायदा क्या है सब बताया है मेरे को अभी मैं सिंसियरली कर भी रही हूँ मेरे से ज़्यादा मेरे रिलेटिव्स बहुत खुश है मैंने लास्ट मतलब डे बिफोर yesterday मैंने मेरा 75th हैप्पी बर्थडे मनाया है वो भी पब्लिक होटल में गैदरिंग के साथ
This is what we have achieved with this patient after 3 months of pulmonary rehab. Only 2 contact sessions a week, not more than that. And we could make a difference. We could breathe through it, and she has risen above it. And we have made her socialized in the community. She was fearless to go out and celebrate her 75th birthday with her family members. So this is what we believe in. Her recovery was our mission. One success story to share with you all, and this is what I am proud to share with you, that now it's a family thing between us. So this is where every one of us, should aim to achieve. Pulmonary rehab is not just about सांस लेना and सांस छोड़ना. So this is just a compilation of all the patients that we have treated with sir. This is my journey of a couple of patients of data that we have gathered, and these are in the best of their health status. So now that we were treating them and we aimed that there shouldn't be any exacerbations, there should not be any hospitalizations, and they should be able to carry on their activities of daily living without dyspnea. That's the only aim that we carry with these patients, and I'm hopeful that we would take this journey forward with all the postgraduates, with all the pulmonologists. Without their support, it won't be possible. And thank you, One Healthcare, for giving me this opportunity to share what I believe is needed in the society. Thank you, one and all.
Uh, Thank you so much, ma'am. Now we'll proceed with panel discussion.
हाँ बोलो बोलो सबको हाँ चेयर अरेंज कर लेते चार
Proceeding with our panel discussion, I would now like to invite Dr. Praveen sir, Dr. Pooja ma'am, Dr. Lajwanti ma'am, and Dr. Kevin Agrawal sir. I would like to invite Dr. Gyan Mishra sir on stage.
okay. So this panel discussion is just to get an insightfulness about the pulmonary rehab practices around the city with a chief pulmonologist amongst us. So the first question is for Sir. Yeah, I have the questions. Yeah. So, sir, would you, Gyan Mishra, sir, this is the first question that I would just want. Kindly, can you please share your experience on how to get a pulmonary rehab program running successfully? So, if you can just put a little light on us and share what you believe is necessary for running a pulmonary rehab program successfully.
So the most important and the first point here is the patient counseling. Uh, right now, we are doing one study on post-TB sequelae in our department, and there the means we are telling them regarding pulmonary rehab, but the acceptance rate that is quite less. That is near about only 40%. Means 40% they agree, and out of them, then again, most of them they are lost to follow. So in the end, let's say out of 100, you are left with 3 or 4 who complete the program. So most of the times the patient is not convinced that okay, is this as effective as medication therapy? And in Goenn setup, we have our own problems. Many of them are financial, economic constraints. So in cases of like COPD and asthma, the patient does not take the inhalers itself. So convincing the patient regarding pulmonary rehab, it becomes difficult. But once you overcome this hurdle, then that can be done. Initial means minimum, I think it should be a 6 weeks program minimum. That is what is recommended.
Yeah,
that it should
6
be
to 8
minimum
weeks.
6 weeks program.
Yes.
So once that is done, then we can again extend it. So counseling, that is the most difficult part. And once we do it, then it can be run.
Okay, thank you. Thank you so much, sir. So the next question is for Dr. Praveen Kumar, sir. Sir, kindly enlighten on what are your expectations from pulmonologist while referring patients to pulmonary rehab.
As already sir has told you that the basic problem is with the counseling, and any of these disease process, especially of the pulmonary system, usually takes a long time for him to become better, because subsequently when the lungs are becoming weaker, there are so many opportunistic organisms which are hitting the patient repeatedly. So maybe first time when the pulmonologist is seeing the patient, maybe he is with a TB. Maybe after 15-20 days, this is my own personal experience, when we go around and see, he's landed up with some pleural effusion or some other, problems. And secondly, if you see, as far as I as a physiotherapist look into that, what is that I am expecting from a pulmonologist when he is referring to the patient? The most important thing is we have to collaborate, number one, and we are all working good. We are all doing good job in our own work, in our own setups, own workplace. But now it is the time has come where we have to collaborate. And each one of the physiotherapists, what I feel now, earlier when we had started a cardio physiotherapy in my college, we had only 2 seats. Now in my own college we have 12 seats. Like that, whole everywhere cardiopulmonary physiotherapists are increasing, and at the same time one-to-one collaboration. So as a physiotherapist also, what we expect from a pulmonologist is, number one, the exact diagnosis. Most of the time what is happening is when the patient is coming to us, he is coming with all the old reports which have got no it is not at all any significance as on date. Number second is the pulmonary function testing. This is again missing. Most of the time pulmonary function tests are not available. Number three is dyspnea levels. What is his current dyspnea levels? And then as Pooja madam has showed you so many videos and all that, what is his quality of life? So these are the 4 things. Most of the time in my practice, I've seen that patients are not coming to any of the pulmonologist or a physiotherapist because they're scared to come out of the home only. So when they're scared to come out of the home, there's no question of going to a pulmonologist. So along with these things, what is the outcome which is the pulmonologist wants from a physiotherapist? That is equally important, because when we are getting some referrals, but they are not referring what should be the ultimate outcome of the patient. So until unless the challenges are not posted by the pulmonologist to the physiotherapist, it is just we are doing the work in silos. So this is my take on that.
Thank you so much, sir. Just to add on to it, we get patients only in acute exacerbation. So what do you all expect from us? In the acute exacerbation period, the patient is so fearful that what do you want? The patient is so much dyspneic. So teaching them breathing exercise in that acute exacerbation phase becomes so difficult. So the message here is we must send patients who are clinically stable to avoid hospitalizations in future and to improve their quality of life, to improve their exercise tolerance. So thank you so much, sir. Well taken. So the next question is for Dr. Lajwanti. Ma'am, what are the challenges in an institutional setup while running a pulmonary rehab program? If you can just enlighten us.
Coming to the institutional problems now, it is never prioritized because we are not in emergency situations like cardiac surgeries or any other surgery. So pulmonary rehabilitation is most of the time taken for granted. Like even if not done, we will get some of the other symptomatic relief from medication. Another challenge is faced is how much financial, which is a very important perspective if we look at patient perspective. Because initially they go through so many procedure investigations, then they consult pulmonologist. Even in our government setup also, the patients are not that much financially stable to come for pulmonary rehabilitation each and every time. But now there is a chance for telerehabilitation which can solve some of the problems pertaining to the transportation of patient. And another important aspect is reimbursement. Most of the things are reimbursed in the medical insurance policies, but pulmonary rehabilitation is not yet covered in our Indian setup for reimbursement. Another thing which I find is how much staff is available in an institutional basis, because institution will be having students also, there will be college, faculties are more of the involved in some administrative type of work. We don't have purely clinicians working on pulmonary rehab. Even if we have the intent to do, how much time we are spending with the patient? As sir has already talked about counseling the patient. Patient education is the first thing, a part of pulmonary rehabilitation, where we need to educate patient ki why it is important, how will it change your quality of life, your perception of dyspnea and other things. That thing need to be only it will happen when we will have one-to-one consultation. But do we have enough that much amount of time, faculty or even our PG students, are they that much trained to have one-to-one consultation? No, there is a problem. Then another problem is how much family members take a role, because chronic pulmonary disease is a disease of chronic, and it mostly the patients are of older age or middle age. So most of the family don't give attention to them, whether they will help in transportation, other financial things. So all this thing overall make rehabilitation in even an institutional setup a difficult.
Thank you so much, ma'am. That was insightful. And the last question is for Dr. Kevin. Kevin, would you like to just tell us what are the pointers can we take from your practice, roaring practice of musculoskeletal rehab, so that we can make pulmonary rehab program successful? Your take on it.
So you guys are already doing exceptionally good. The only problem is, I'll give you a case scenario. A 50 years old man, chronic smoker, climbed a few steps. He is breathless. अब वो एक pulmonologist के पास जाएगा, chest physio के पास जाएगा कि yoga instructor के पास? That is the awareness. योगा वाले के पास जाएगा. अगर उसका प्रॉब्लम बढ़ा, then he'll consult a doctor. That is true. What we are doing different is, एक 10 साल का बच्चे को अगर फ्रैक्चर हो गया, या उसको पूछा फ्रैक्चर क्या होता है, बोलेगा हड्डी टूट गई. उसको पूछेंगे COPD क्या होता है? Awareness नहीं है. So when we talk about awareness, we are talking about patient and doctors. General population किधर गया? We as sports and musculoskeletal guys, हम लोग इतना awareness create करते हैं कि people know. पेन आया तो ठीक है, स्प्रे मार दो, ठीक नहीं हुआ तो डॉक्टर को दिखा दो, उसके पास चले जाओ, इसके पास कर लो, तेल लगा लो. ब्रेथलेस हुआ तो क्या करना? Nobody knows. So I would again and again stress on one thing. We are working on patients, we are working on pulmonologists and on physios. Why not work on the general population जिसको आइडिया ही नहीं है कि ये सब चीजें होती है. अब जब एक्सेप्टेंस ही नहीं है, उनने कभी देखा ही नहीं कि चेस्ट फिजियो होता है, पल्मोनरी रिहैब होता है, देन इट्स समथिंग न्यू फॉर हिम. आई विल ही एक्सेप्टेड रातों रात. कल तक तुम्हें ठीक ताज बोल रही है, करो. सो दैट इज व्हाट वी आर डिफरेंट एंड that is what we have to do.
Yeah, thank you so much. Well taken, Kevin. Thank you so much. So that any questions from the forum, please, the forum is open for question and answers. If you have, the postgraduates especially, if you have any queries or if you have any doubts, anything that you want to ask, it's a very good opportunity to interact and get your doubts cleared, especially the JR students, the junior residents. No questions? So we are stuck in level 1 itself, awareness.
Like everyone is aware of yoga. So even during clinical practice, as a physio, if we are going for an IPD patient who is admitted as a prophylactic pulmonary rehab also, the first thing they'll say is, हम daily अनुलोम विलोम करते हैं, हम daily yoga करते हैं, भ्रामरी करते हैं, and all those things. They'll not accept to your breathing exercises that easily as they'll accept to other medications and other things. This is what I have seen in indoor patients as well.
Right. So there is a need to celebrate a National Pulmonary Rehabilitation Day. Day before yesterday only we celebrated International Yoga Day. So let's start with national. We'll start with Nagpur Pulmonary Rehab Day soon, and I'll be hosting the programs, and I'm giving an open invitation to all of you right now. So yes, guys, thank you so much. Thank you, panelists, for your valuable time, your insights. Yes, please.
Good afternoon, everyone. So I wanted to add a thing and also ask a question. That pulmonary rehab, I think, is not only limited up to pulmonary conditions, because also we see a need of hyperinflations or various other breathing exercises, pulmonary rehab, in upper abdominal surgeries as well, because yes, the diaphragm is in relation with upper abdominals. So sir, what's your take on that, and how should we actually deal with not only pulmonary rehab in pulmonology sector, but also apart from that various surgeries? So yeah, that's my question to all. Like it's open for all.
That is definitely a need in pre-op period as well as in post-op period. Okay, so one lack of point that we have identified is that there is a lack of national guidelines in pulmonary rehabilitation. There is a national non-communicable disease program which runs. So that is COPD, asthma, everything. In that, in just one line or two line, they have mentioned pulmonary rehab. So maybe if the society comes up with a national guidelines on pulmonary rehab and gives to the government to include in the NCD framework, then that will be applicable everywhere in the public sector as well as in private sector, and you can have all the comprehensive indications listed there, that these are the indications. So someone has to take an initiative and make a national guidelines on pulmonary rehab, which should be updated one. The UK has one, the different countries have, but as of now I'm not aware of any updated guidelines with us. Yeah, we do have many journal articles, review articles, updates, but national guidelines as a part of national non-communicable disease program, it should be there. Then most of the problems will be solved.
Thank you, sir.
Apart from this, recently WHO has contacted our head of the Department of Pulmonology that how to go about making protocols at your institution. And Sontakke sir was here in the morning. So we are trying to work on that. But in the meantime, what I feel is the basic as a physiotherapist, when you are seeing any patient, first just see him as whether you want to do a preventive strategy, whether you want to do a therapeutic strategy, whether you want to do a rehabilitative strategy. So this is very important. Most of the time what happens, patient is coming with the idea of getting treated and we are giving preventive strategies ending home. He is coming with a therapeutic model to us. He wants some therapy. You are giving him a rehabilitative strategy which he has to utilize after 4 months or 5 months. So basically what is asked, we have to serve what the patient wants, not what we know. Most of the time what is happening is we are trying to serve what we know, not what the patient needs. So if we can bridge that gap, and what is happening in the yoga is, in the yoga what they are doing is what the patient needs is being served. So that is the basic difference. It is not that we are all knowledgeable, but we don't want to go to the level of the society and then bring about some change from there. Once we start doing that, then it will be much better. The same model has been replicated in the cardiac setup, if you can see. For 20 years down the line, right, when this cardiac setups was not so many, now we have got so many cardiac setups now. And if you can see, each and every cardiac setup has got a physiotherapist now. You can visit any hospital, right? And even before the surgery also, they ask for the clearance from the physiotherapist whether the chest is clear. So this is the level at which the cardiac is going on. But maybe somewhere we are lacking, where we can come together, collaborate, And maybe this is a good option now. Albert sir has got all the details of how many pulmonologists are there, how many physiotherapists are there. We can have a small diary or like that. So what happens is pulmonologist need not search a physiotherapist. Physiotherapist need not search a pulmonologist. So automatically what happens is if you can see somebody from Adilabad is here, right? So if you have the list that Adilabad mein this physiotherapist ko thoda bahut pulmonary rehabilitation ke malum hai, and then they can collaborate, and that is how we can do it. If we can do it, it is wonderful. And here I would like to add one important thing is because so many pulmonologists are there, so many people are here. I am representing the MUHS also, so it's an open invitation because now MUHS has come with a Chakra, which is a Section 8 company, right? If you have any of your innovations, right, or anything which you want to produce on a larger scale, we are acting as an incubation center. It is in the form of a hub and spoke model. So we will be trying to help you out with that incubations or further developments of that. So if anything can be done in the pulmonology, I would be happy to help you out with that, with all the processes. It was inaugurated by our honorable CM, and already about 1 crore every year is going to be given there for that incubation center, and a lot of other things going on. So if you all can collaborate, I can think we can do great things. Thank you.
Thank you so much. So we will end the panel discussion, and the forum is open for the hands-on workshop. The stations are already ready. So before I thank the panelists, thank you so much for your time. And that wonderful movie was made by my postgraduate students, Dr. Avanti and Dr. Siddhida. So a round of applause for both these students. It was not possible without them. So whatever work if I do and if I'm not able to present to you all, then thank you so much. So thank you one and all. So the forum is open for hands-on workshop. Thank you.